All right, so with hemodynamic monitoring, anytime we're measuring flow or pressures in the cardiovascular system, that's called hemodynamics. So fancy word for pressures like blood pressure, pulmonary artery pressure, all of those are considered hemodynamics. Name some reasons why it is necessary to monitor a patient's hemodynamics. So here we are, respiratory therapists, we specialize in the lungs. Why do we have to know about hemodynamics? So it tells you why it's important for a respiratory therapist to know about hemodynamics. We want to ensure oxygen delivery to the tissues of the body. So that's why we look at hemoglobin level, how saturated the hemoglobin is, because we want to make sure that that oxygen gets delivered to the tissues. Diagnosing, knowing pressures in different parts of the body may help to diagnose the patient's illness. So when we were looking at a high pulmonary capillary wedge pressure, it's an indicator that the patient has heart failure, or if the wedge pressure is normal, yet we still have a lot of edema on chest x-ray, it could be ARDS. So it helps us to understand, helps us with diagnosis. A respiratory therapist needs to know if the patient is hemodynamically stable as part of their assessment. So when you go into the room in the morning and you're assessing everything going on, why is it that you look at blood pressure, you look at pulmonary artery pressure? It's to determine, let me get some. Good as it gets. To determine if a patient is tolerating their ventilator settings. So if they're not getting enough support from the ventilator, it can cause cardiac arrhythmias to occur. It can make their blood pressure high. It can cause tachycardia. So that's why you're looking at their hemodynamics. It helps you evaluate the patient's weaning status from the ventilator. So if you put the patient on CPAP pressure support, how are you supposed to figure out how well they're doing? Yes, there's certain things you look at on the ventilator, but you also want to look at hemodynamics. What is their heart rate? Is their blood pressure stable? And then to determine if a spontaneously breathing patient is so unstable that they may require intubation and mechanical ventilation. So how do you recommend whether a patient should be intubated and put on the ventilator? And what if they can't maintain their blood pressure? Now they've got altered mental status. Is their airway safe in that circumstance? And the answer is no. You would recommend that they be intubated and ventilated. What happens to the organs of the body if they don't receive proper flow? And then it gives you the answer to the question. It says lack of oxygen for 4 minutes will cause damaged tissue. That's not a very long time. So the most susceptible organs are the brain and the kidneys. So it's not the heart. The heart can go about 10 minutes before it stops working. But after 4 minutes, brain tissue starts to die, and then the kidneys shut down and don't do well. So sometimes you'll have a patient who goes to surgery. They were doing fine before surgery as far as having a good urine output. And then after surgery, there's no urine. What happened during surgery that they don't have a good urine output? And it could be during surgery, they became very hypotensive. Maybe there was a lot of blood loss. And the kidneys were not being perfused adequately. And then after surgery, the kidneys pretty much shut down because they no longer function because of the damage that ensued from lack of perfusion. And you'll see that post-code. Sometimes you'll get a patient resuscitated, you'll get a good blood pressure. Neurologically, they could wake up and then they don't have any urine output. So during that time of cardiac arrest, the kidneys were damaged from that lack of blood flow, and then they don't come back. So, yeah, the kidneys are very susceptible to low blood flow. How are hemodynamics monitored? By measuring pressures. We need the equations for all of these. You guys remember all of these equations?
Oh, no.
No?
Nice.
It's a good review then, isn't it?
Taking it back to semester one.
Yes, so you'll review it now. You'll review it next spring before you take the national exams. So hopefully all this repetition makes sense. So for blood pressure, remember that it was systolic plus. Yes, there you go. What's that? Mean arterial blood pressure? Yes. So mean arterial pressure, not to be confused with mean airway pressure. Systolic plus 2 times diastolic and divide by 3. So if you put in a patient's blood pressure into these numbers, you should come up with 93.3. Wow, very good. And when we're measuring pressures in the blood, it's always millimeters mercury. When we're measuring pressures in the airway, it's always centimeters of water. So the next one is systemic vascular resistance. Do you need me to write down what SVR stands for?
No, I equation.
A normal mean arterial pressure. So I just want to say 93 is normal. So if you have a blood pressure of 120 over 80, and you plug that into the equation, you'll come up with 90. All right, so systemic vascular resistance, we're looking at the beginning pressure right after the left ventricle. So we're sitting in the aorta and we're measuring the pressure in the aorta. Then we measure the pressure on the right atrium, and we subtract the 2 to get the difference. And that tells us the pressure difference in all of the blood vessels. So that's your vascular resistance. So we need to know the mean arterial pressure as our starting pressure. The central venous pressure or right atrial pressure. Pressure overflow gives us resistance, and we use cardiac output. And then there's units of resistance, and it's got the fancy words, dynes per second per second. Yeah. Normal. So if you plug the numbers in and they come between 900 and 1400 dynes per second per centimeter to the -5, that's a normal systemic vascular resistance. And then pulmonary vascular resistance is looking at the pulmonary artery pressure. The ending pressure would be over on the left heart. And the way we measure pressure on the left heart is we wedge the catheter into a vessel and get a reading. That reading reflects what the pressure is over on the left side of the heart. So beginning pressure would be the mean pulmonary artery pressure. That's speaking. The ending pressure would be pulmonary capillary wedge pressure. $100 to $250. So does that help you to remember it if you think about beginning pressure and ending pressure?
Yeah.
So pulmonary resistance, you're thinking about beginning pressure in the pulmonary artery and the ending pressure. And how do you remember to divide by cardiac output? Pressure over flow, maybe? Flow could be cardiac output? No. All right, so just remember that. What about the units of 80? Is that kind of stuck in your mind?
Yeah.
First semester?
Yeah.
Yeah? No, I hear a high line sound.
Remember the normal.
Converted to resistance of Downs facility. Yeah. Yeah, it's easier the second time. Promise. No. Alright, so that was it for formulas. And to,
You don't need CVP.
so CVP is the pressure reading from the right atrium. It's called central venous because you've got the superior vena cava and inferior vena cava draining into the right atrium. So that's considered central venous pressure. So CVP, right atrial pressure, or RAP, is 2 to 6. So not much pressure in the right atrium. There is high pressures from somebody has pulmonary hypertension or right heart failure. Those pressures are high over a long period of time. That's when you start seeing your atrial fibrillation, your atrial flutter. Just figure out how it all for you. And then a normal pulmonary artery pressure. So there's a range. Well, I'll put down the range. One way that it helps to stick in my mind, and if you ever get a dozen bagels, do you know how many bagels are in a dozen? 12. 12.
Baker's dozen.
Baker's dozen.
So let's not do the baker's part. So a dozen is 12. So I remember 2 dozen over 1 dozen is a normal pulmonary artery pressure. So that would be 24 over 12. Now I'll give you the range, but that's just for me to get into the ballpark. So if you're quickly asked, what is the normal pulmonary artery pressure? Maybe you've got the range memorized, so 20 to 30. For the pressure during systole. So the heart contracts, it pushes some blood into the pulmonary artery, goes between 20 and 30. And then during the relaxation of the heart and the lowest pressure in the pulmonary artery, the diastolic pressure, 6 up to 15. You don't have to memorize mean pulmonary artery pressure. Could you find mean pulmonary artery pressure if you were given these numbers? Like, this isn't on the exam. I'm just trying to stimulate your minds here. What is the mean pulmonary artery pressure if a patient has a PAP of 30 over 15? So it would be the same thing as this one. So systolic is 2 times diastolic over 3. So 30 plus 2 times 15, another 30. So 30 plus 30, 60. And then divide 60 by 3. 20. Yeah. So 30 over 15. Mean pulmonary artery pressure equals 20. Did you have to study pulmonary hypertension as one of your diseases?
Yeah.
Yeah, pathophysiology. Did you have to know at what point it's, the pulmonary pressures are considered pulmonary hypertension? So when it's higher than 20, it tells you that the patient has pulmonary hypertension. That's when we need pulmonary artery pressure. Sorry. Yes. When pulmonary artery pressure is higher than 20, that tells you the patient has pulmonary hypertension. Do you know why people get pulmonary hypertension? No. Why? Why is it?
Black.
You said it low because you're not sure. But when you say it low, I can't hear.
Like plaque buildup, your ventricles aren't able to pump. Like, they're pumping against a harder resistance and causes hypertension.
The pressure builds up in the lungs, right?
Yeah, something goes on in the lungs. Do you know?
Can you get it with, CHF, what numbers?
Yes. What else? COPD and hypoxemia?
Right side of our screen.
Yeah, so when a patient has a fibrotic lung disease, COPD, trying to send blood flow through those diseased lungs, it's not easy. And it creates a lot of back resistance, and that's why they end up with heart failure, right heart failure. So somebody who's got lung disease, has pulmonary hypertension, and eventually they get right heart failure. Does it make sense? Yeah. Yeah, so hypoxemia constricts the vessels. Let me go to the next slide and write down, do you remember cardiac output? Heart rate times what? Stroke volume, yes.
Between 4 and 8 meters.
Yes, very good. A normal cardiac output for adults, 4 to 8 meters.
I'm assuming we're gonna have math questions on this next exam.
Yes, correct. Yvonne, you know I do. But you do really well with it. So it's amazing you can do something and still do well. And then ejection fraction. Okay, if you don't remember that one, it's okay. I forget.
Wow. Stroke volume divided by end diastole.
Yeah.
Multiplied
So
by
when you're looking at ejection fraction, you need to know how much blood is in the ventricles before it contracts. And then after it contracts, how much blood left. And you come up with a percentage. So when the heart contracts, I used to think that when the heart contracts, all of the blood is gone. Like if you have a healthy heart, all of the blood in the ventricle goes into the aorta. So I was amazed that no, normal is 55% of the blood in the ventricle leaves the heart when it contracts. Which actually makes sense, right? Can you imagine an empty ventricle? No, it can't be empty. So 55% is a normal ejection fraction. So equation, stroke volume would be how much blood left the ventricle. And you compare that to how much blood was in the ventricle before it contracted. So stroke volume divided by end diastolic volume. Do you need me to write that out or do you remember that? So if you see EDV, you're going to know what it stands for.
What's the formula for that? What formula are you going to use?
To find ejection fraction. And then normally it's 55% to 60%. So a healthy heart will eject half of the blood volume. So when patients have an ejection fraction that's less than 35%, that's considered severe. Let me just read it here. Severe heart failure, yes. So if you have a patient on the ventilator and you're trying to wean them, and you look in the medical record or you get it in report that their ejection fraction is 35%, they're going to have a hard time breathing. Do you remember the connection between the two? If your heart can't eject blood, it backs up into the pulmonary circulation. When you have a lot of blood in the pulmonary circulation, it'll leak through the capillaries into the interstitial spaces in the lungs. And boy, is it hard to breathe if you've got a lot of fluid in your interstitial spaces. So you'll try to wean the patient and you'll see them having a real hard time. Their respiratory rates go up in the 30s. Accessory muscle usage is just really hard. It makes the lungs stiff. It would be like having fibrotic lungs and trying to breathe with all this fibrosis. So that's the connection between heart failure and difficulty breathing. So all the fluid backs up into the interstitial space. And then you'll see all the infiltrates on your X-ray. So that's why that becomes important when you're getting a report, knowing what the ejection fraction is. Okay, the rest of these are questions, so we'll go around the room and see if you can answer them. Tiffany, you're next. I'm teasing. So how is pressure measured in the right atrium? Do we call that the systemic vascular resistance? Do we call it diastolic blood pressure? Do we call it central venous pressure, right atrial pressure, or both C and D? E, yes. We could call it central venous pressure or right atrial pressure. Brent, you next. What would cause right atrial pressure to be high? If the patient has right heart failure, if the patient has left heart failure, if they have hypervolemia, excess volume in the blood vessels, or could it be all of the above? B as in boy? Yes, very good. So all of these will cause increased pressures in the right atrium. Do you understand how left heart failure causes high right atrial pressures? Tijin, do you know? So right heart would be the right ventricle is not able to pump out an adequate amount of blood. And if it can't pump it out, it backs up. And that makes the chamber before it have high pressure, high volume, therefore high pressure. Yeah, so everything backs up and causes the pressures to be elevated. So same thing with the left heart failing, everything backs up in the pulmonary circulation and eventually it'll affect the right heart also. So does left heart failure lead to right heart failure? Yes. And does it make sense to, with hypervolemia, when you have high amounts of volume, you're going to have higher pressure? Marlon, you're next. What is a normal pressure in the right atrium?
D.
Yes, correct. So 2 to 6 millimeters mercury. Mary, how is blood pressure measured? With a sphygmomanometer, a blood pressure cuff, arterial pressure line, or all of the above? D as in dog? Yes, very good. Sphygmomanometer, what is that? A blood pressure cuff, yes. Have you had any patients with arterial lines in?
Yeah.
And you see the arterial waveform on the monitor? Everybody? Oh, yeah? Which of the following are considered normal blood pressure for an adult? So it goes to Rachel. So 140/90. Does that seem like a normal blood pressure? Yes. So
Like seem to be relatively, it's low, but he has the systolic side, so.
okay, so it's kind of hard to say normal, right?
Yeah.
All right, so let me give you some notes on normal. So hypertension is considered 140/90 millimeters mercury. I think that's been lowered, but I'm going to continue teaching it like this until your textbooks change. So 140/90 is, and higher is considered hypertension. And this is for adults. And then hypotension is 90/60. So I put less than in front of it. Because if 90/60 and lower is considered hypotension, what if it's 90/60? Is that okay? So sometimes yes, sometimes no. So I'll put it hypotension.
So I guess now we look.
So looking at diastolic pressures. Indicate hypertension and hypotension. So if you have greater than 90, greater than or equal to millimeters mercury, diastolic pressure, that's considered hypertension. Less than 60 diastolic is hypotension. All right, so 140/90 we said is hypertension. What about 150/80? Look at diastolic pressure when you're deciding if it's hypertension or not, because when we exercise, our systolic pressures will go up, and that's normal during exercise. So 150/80, if that person is exercising or anxious, it's the top number goes up, but it's the bottom number that'll tell us if we have hypertension. So what about B? We're okay. C, 90/60. That's the beginning of hypotension. And then what about D? That's very hypertensive, right? That's a stroke waiting to happen right there. That's pretty high. So is anything considered normal? Maybe 150/80, since it's in the range for the diastolic to be normal.
What about 90/60? Since if you have less than 90/60, it's hypotension. What if it
Good
is?
point. So maybe we could include that as normal. Because we say less than 90/60, so what about 90/60 itself? Is that considered normal? Yeah, it's like the beginning of abnormal, I guess.
Honestly, the other patients there are not maybe the basic persons.
They did, a 90/60. Okay. All right, so then let's do this. It's less than or equal to 90/60 is hypotension. What causes high blood pressure? Oh, this goes to Summer. Does increased vascular resistance increase blood pressure?
Yes.
Does increased volume in the vascular space increase blood pressure?
Yes.
Very good. So it's all of the above. So increased vascular resistance, that's when we get our vasoconstriction. Having the heart pump against those constricted vessels, it's going to make pressures higher. It's going to have to pump harder. When we were talking about systemic vascular resistance, there's another word that you'll hear used, especially if you're doing your rotation in the HSU, the heart surgery unit, or CVICU, cardiovascular ICU. So I think they have different names at different hospitals. They talk about afterload. And they want to reduce afterload. Do you know what that means, or?
This is local non-vegetables after, it's from done. What's often vegetables after 60 or,
You're thinking of preload. What's in the ventricles, before it pumps. Talking about afterload is actually talking about systemic vascular resistance. So if we want to decrease afterload, what has to be done? So that's what you'll hear them talk about. How can we reduce afterload? How do we reduce systemic vascular resistance? Tijan? Yeah, that would help. If there's less cardiac output, there'd be less blood pushed into the vessels. Is there anything we could do to the vessels to make the pressures lower?
open them up.
Right, vasodilators?
Oh,
Yeah. Yes, very good. How is resistance in the systemic circulation measured? This goes to Tiffany. Letter A, very good. The mean arterial pressure minus CVP, divide by cardiac output and multiply by 80. Tijan, how is pressure in the pulmonary arteries measured? With a blood pressure cuff, via thermodilution, a flow-directed balloon-tipped catheter, Swan-Ganz catheter, or both C and D? Very good. So letter E. So flow-directed balloon-tipped catheter is what you see on your national exam, because they can't use name brands on the exam. But at the hospital, they'll just say the patient has a Swan-Ganz catheter in. And it's a yellow catheter coming out of the subclavian vein. Have you seen that on your patients?
Yeah.
Just a couple of you have? Chris, which of the following are normal pressures in the pulmonary arteries? 35/15, 24/10, 18/4. Letter B? Okay, very good. So it's close to that 2 dozen over 1 dozen. Or if you remember the range for systolic pressure in the pulmonary artery, 20 up to 30. Or 6 up to 15 during diastole. Wisbeen, why does lung disease lead to increased pulmonary artery pressures? Circle all that apply. Chronic hypoxemia causes pulmonary vasoconstriction.
Yeah.
Yes, okay, that's one of them. So if you have bad lungs and you're not oxygenating well, the feedback is the body will constrict the pulmonary arteries. I'm thinking it's to push the blood flow, like if you squeeze something, you empty it quicker. So maybe that's the body's thought, let me get more blood flowing to the lungs. But pulmonary artery pressures go up with hypoxemia. So yes to A. What about number B or letter B?
Yes.
Reduced capillary bed from loss of capillaries and alveoli. So you get a reduced capillary bed from, what is it, emphysema, where you lose alveoli and you lose the capillaries.
That's one of those COPD.
Part of COPD?
Yes.
COPD?
Mhm.
Okay. And what about, having blood clots? You don't really lose your vessels, but you lose blood flowing to those vessels. So if you have less pulmonary capillaries, that pushes the blood into the remaining pulmonary capillaries and you end up having higher pulmonary artery pressures. What about letter C, Ms. Bean? Stiff lungs make it difficult for blood to flow?
I'll say yes first.
Yeah. So if you have pulmonary fibrosis, what is it, scleroderma? It's probably fresher in your minds than mine. Different lung diseases that when the lungs become stiff, it also hardens the capillaries. I think that just affects the airways. So things like scleroderma, sarcoidosis, I think that affects the actual vessels themselves. Or D, only heart failure causes increased pulmonary artery pressures.
No.
No. Okay, very good. So we've got a lot of causes, something going on with the lungs and heart failure. Taylor, which of the following would not cause pulmonary artery pressures to be elevated? What if the inferior vena cava becomes blocked? So if it's blocked, you're going to have less blood flowing back to the right heart.
I would go with that vasoconstrict. Is it A? Because it can't get to pulmonary artery.
So what about a blocked inferior vena cava? Would that cause pulmonary artery pressures to go up?
No.
No. Okay. So that's one of them, right? We're looking for things that don't cause high pressures. So if you block the blood flow, you're not going to have high pressure.
Yeah.
So let's go with A. What about B, left heart failure?
That would cause pressures to be elevated.
Okay, so, and we're looking for things that won't elevate, so we won't choose that one. What about C, hypoxemia?
I would think that's also gonna elevate
Mhm.
pressures.
Very good. So hypoxemia does constrict the pulmonary vessels and does make the pressures go up, and we're looking for not causing it, so we can't choose that one. What about lung disease?
Yeah. Or
So lung disease could make it harder for the blood to flow to the lungs, and it could also constrict the vessels if it's hypoxemia. So that'll make the pressures go up, so we can't choose that one either. What about acidosis? Do you remember the effect of acidosis on the pulmonary vessels? It constricts the pulmonary vessels also. So the only one we had was the blocked inferior vena cava, which would stop the blood from flowing. Okay. Don't you hate those questions where it's, You figure out what it is, and then you have to figure out what it's not.
Oh, question. Any multiple? Like.
Any multiple is,
That's what I'm thinking about, when it's not. I'm eliminating.
oh, I see. Gretchen, how is cardiac output measured? Oh, Corinja. Sorry. How is cardiac output measured? All of the above. Very good. Gretchen, which Swan-Ganz catheter measurement reflects the pressure in the left ventricle during diastole? Very good. The pulmonary capillary wedge pressure. Good job. How is ejection fraction measured? We're back to Danielle. Yeah, you're looking for stroke volume over end diastolic volume, but it doesn't say stroke volume at the top. So how would we get stroke volume? It would first have to be the volume before the heart contracts, so EDV. And then what is the volume after it contracts? ESV. Yes, very good. So letter A is the ejection fraction formula. Brent, name 2 causes of pulmonary edema. Does increased capillary leakage, such as that occurring with septic shock, cause pulmonary edema?
Yes.
Yes. What about increased hydrostatic pressure, such as that occurring with left heart failure?
Yes.
Very good. Ruptured parietal pleura leading to a change in the thoracic cage? Oh boy, no. Remember, if it doesn't look familiar, don't pick it. What about severe stress causing large gasping breaths? Okay, so we have number 1. Very good, letter A. So number 1 and number 2. So I've heard that severe stress or large gasping breaths. So if a person is drowning and they're in the water and they're generating these strong negative efforts because they're starving for air, it can actually cause pulmonary edema to happen. Have you heard of that? Like it's a pulmonary edema with a dry drowning? No? Okay, so then never mind. I don't want to give you too much info. All right, listed below are 2 sets of pulmonary artery pressures along with the pulmonary capillary wedge pressure. Indicate which set of pressures reflects a patient in ARDS. So how would we know if they're in ARDS? Oh, okay, looking at PF ratio. But what about, would a patient have a high wedge pressure if they are in ARDS? Remember when you inflate the balloon, the catheter gets wedged, it reflects pressure on the left side of the heart. Somebody in ARDS, is their heart okay?
No.
It is. Yeah, ARDS affects the lungs. So that's, like a severe trauma leads to ARDS. You've got washout of the surfactant, alveolar collapse, really hard to oxygenate those patients. So that's ARDS.
What if the heart is not okay and blood is backing up and that is causing leakage?
That's left heart failure.
That's left heart failure, and we would know that because the pulmonary capillary wedge pressure reading would be high.
Right?
Yeah, above 12. Yeah. Well, you know what you're thinking of is at what point do you start seeing infiltrates on X-ray? And the pulmonary edema shows up when the wedge pressure is more than 17. So that's why you remember that. That's when you start seeing pulmonary edema on the X-ray. So to determine, is it left heart failure? Is it ARDS? You look at the wedge pressure. If it's high, it's left heart failure. If it's normal, it's ARDS. Should we write that down in our notes somewhere?
What was the range for ECW?
So let me put that first. Normal pulmonary capillary wedge pressure is between 4 and 12 millimeters mercury. That's normal. If the pulmonary capillary wedge pressure is higher than 12 millimeters mercury, that indicates left heart failure. It could indicate hypervolemia too. But right now it's asking us to choose between heart failure versus ARDS. So if the pulmonary capillary wedge pressure is higher than 12, it indicates left heart failure. And then if the pressure goes above so capillary wedge pressure above 17, you will see pulmonary edema on the X-ray. All right, so what if pressures are high in the pulmonary vessels, but you have a normal wedge pressure?
Then it's normal. Yeah.
Very good, yes. All right, we have one more question and then we'll stop for lunch. Listed below are two sets of pulmonary artery pressures along with the pulmonary capillary wedge pressure. Indicate which set of pressures reflects a patient with left heart failure. Who does this go to? I lost track. Marlon?
Left actually, it would be letter A.
Very good. And how did you know?
The capillary wedge pressure.
Is high. Very good. So high pulmonary capillary wedge pressure, you're looking at left heart failure. All right, so we will stop there for lunch. Let me pause the recording. Okay, we'll finish up this lecture before, and then we'll get started on A-lines and balloon pumps. I want to talk to you about induced hypothermia. So having a cardiac arrest, when there's return of circulation, that period of time where the brain was not being perfused with oxygen, it does something to the brain where it starts to swell. And usually the swelling starts increasing, and then by 24 hours after return of circulation, there's a lot of swelling in the brain. So what they found is if they can cool the body temperature down below normal for 24 hours after the insult, I'll call it, the cardiac arrest or whatever, sometimes a stroke, they can do this for a stroke. Keep the body cold, and now you don't have as much damage to the brain from all the swelling that occurs. So that's the purpose for induced hypothermia. So therapeutic hypothermia is another way of referring to the same thing. It lowers the patient's body temperature to a level of 32 to 36 degrees Celsius. And there were studies done that found that whether you cool it to 32 or 36, you get the same neurologic outcome and the same survival. So is it necessary to go down to 32 degrees Celsius? Probably not. So Danielle, Brent, you guys had a patient there. Did you see what temperature the patient was cooled down to?
36.
To 36. Okay. All right. And then it says it's indicated to help reduce the risk of the ischemic injury to the brain following a period of insufficient blood flow. Periods of insufficient blood flow may be caused by cardiac arrest, stroke, or brain trauma. And then it repeats, preventing hyperthermia in patients who experience a ROSC. Do you know what that stands for? Excellent. Return of spontaneous circulation. Following cardiac arrest improves neurologic outcomes. So here it says 55% of patients appropriately chosen. I don't know how they just decided on the best few, but they had good neurologic outcomes post VFib or pulseless VTAC compared to 39% who didn't receive induced hypothermia. So 55% versus 39%. So if you hear a code called and you go to 100 codes in a hospital, I think I was telling you like 20 of them will survive and leave the hospital neurologically intact. So of those 20 people, if you have a group where 10 of them get induced hypothermia and 10 of them don't, will the outcomes improve? And yes, so a few more people have better neurologic outcomes, but I guess it's enough to spend a lot of money on this equipment and to do this on these patients. The goal is to achieve this as soon as possible post cardiac arrest, so within 6 hours of the arrest occurring. So it was being done in the field. So the medics would respond to a code, they'd get a return of circulation, and then they would immediately get the patient really cold. But they're not doing it out of hospital now, they're doing it in hospital. And then how long are they supposed to stay cold before they're allowed to rewarm? And the answer is 24 hours. So after 24 hours go by, they start warming them up. So if they're at 36 degrees Celsius, they don't have too far to go. So within 2 hours, they're going to be back to their normal body temperature. So the Arctic Sun is just one brand of a cooling blanket. It can have cool water circulating through it, or it can have warm water circulating through it, depending on whether we need to warm the patient or cool the patient. This helps regulate the patient's temperature to a set target. What complications can occur if the patient's body temperature drops below 32 degrees Celsius? And crazy things kind of happen. Cardiac arrhythmias start to occur. And blood starts to clot. Hi, Patty. We've got like 45 minutes of lecture before we're ready. Coagulopathy. Doesn't like it. So do you know what coagulopathy means? Blood clots occur. So you get blood clots occurring if the body temperature gets too cold. I guess really cold body causes slow, sluggish blood flow. And when you have sluggish or slow blood flow, that's when the blood starts to clot. So what is our role in hypothermia management? It says to follow a protocol for each hospital. Typically, they'll order blood gases to be done every 4 hours. When you run a blood gas on a patient that has induced hypothermia, you have to remember to put in the temperature that they're being cooled down to. So remember to make that temperature adjustment on the blood gas. It says to set the humidifier temperature at 32 degrees Celsius. So on the Fisher-Paykel humidifier, we can't control the temperature. The thought, I guess, is if that's being warmed up to 37 degrees and going into the lungs, it's kind of warming up the patient. So that's why they're not recommending that we use 37 degrees Celsius inhaled gas to deliver to the patient. So how would you get 32 degrees Celsius? You can't. You could turn it to non-invasive setting. That brings it down to 35 degrees. So that would be your next best option. Could you change to an HME? And the answer is yes. So the body's natural response to a cold body temperature is to shiver. And when you shiver, your muscles are contracting, and muscles contracting produce heat. And that's what keeps us warm. So the body is going to try to keep itself warm. So if it's 36 degrees Celsius, if the patient is not heavily sedated, they're constantly going to be shivering because their body wants to warm up to 37 degrees. So it requires analgesics, so pain meds, your morphine, fentanyl, a sedative, that's your Precedex, propofol, and also a neuromuscular blocking agent. So if you have a neuromuscular blocker, what are you guys seeing used? Like rocuronium is probably the most common.
Yeah, if someone wants.
And then which one is short acting? Very good. And then sedation is weaned once the temperature is at 36.1. Well, that doesn't make sense. I would imagine their sedation is weaned when they're back to 37 degrees. All right, so that ended that PowerPoint. Do you have any questions? So this, it says to list the expected hemodynamic changes in specific clinical conditions. So together we'll go through, we'll fill out this box. And then below it said, and there's like 8 questions, 8 questions split into groups of 2 or 3 students. Discuss the answer to the following questions using the hemodynamic information from above. I don't know if we'll have time to get into groups. So what you can do is do this on your own, and then we can discuss it during the review. When is the review, you ask? I don't know. When do you want to review? The final is on Tuesday. Friday.
Getting recorded.
Yeah, the recording, I think, is a lot more helpful than you think out.
Oh, okay.
I think.
Okay. Why is it more helpful?
It's a lot of us can't make it to that physical review.
No, for this last exam, I gave you guys a list of what's on the exam,
Oh, you mean, okay.
compared to me reading what's going to be on the exam.
Maybe it's just the way I learn when I hear you say it, I remember it better
I can
than like reading it myself, and I listen to it in the car, I listen to it on
Yeah,
work.
I agree.
It's repetition.
Oh, okay.
I do the same.
All right. So, Thursday afternoon or Friday is good for me. You guys get out of clinicals at 3. You have to work at 4. Would that be a good time?
We don't have clinical on Friday. Yes, we do.
This
Then I'm being makeup.
This Friday,
Yeah,
this
this
next
Friday,
Friday,
next Friday.
Oh, okay.
Might be the last one.
So you have clinical Friday and next Wednesday?
Yes.
Okay. How many people have to make up a day on Friday? Nobody? Next Friday, like a week from this. Friday. Just you? Oh, okay, that'll be fun. So let's fill out the top part of this form. All right, so how can you tell if a patient is having cardiogenic shock? Like, what are the telltale signs of cardiogenic shock? Will there be, the first column is evidence of pulmonary edema. And in that box, you can put yes. So we know that in cardiogenic shock, the heart muscle is weak. When it contracts, it's not pushing out the normal amount of blood flow. And that's when everything backs up into the pulmonary circulation. And that's why we see a lot of infiltrates on chest x-ray because of all the engorged capillaries that start to leak when the left heart fails. So yes, we'll see pulmonary edema. Will pulmonary artery pressures be elevated, low, or normal? So when you have blood backing up from the left ventricle into the pulmonary circulation, it's going to have a lot of volume in the pulmonary vessels. That's going to make pressures high. So you could put arrow up for pulmonary artery pressures. Or if you want to write the word increased. And then if there's a Swan-Ganz catheter in and you wedge the balloon into a vessel and you get a high wedge pressure reading, does that go along with cardiogenic shock? Yeah, so for that one, put arrow up or write the word increased. The cardiac output and the cardiac index are going to be lower than normal because the heart's not ejecting the normal amount of blood. So put arrow down for decreased, so decreased cardiac output. And then when the body's response to a low cardiac output is to constrict the vessels because it's trying to get more perfusion to certain areas. So there will be a lot of vasoconstriction occurring, and that'll cause the systemic vascular resistance to go up. So increased systemic vascular resistance or arrow up. And then the mean arterial pressure is the MAP. MAP will go down because of that low cardiac output. So arrow down or blood pressure down. All right, the next one is ARDS. Is there pulmonary edema in patients that have ARDS? Yes. So write yes in that box. And then for pulmonary artery pressures, sometimes they're elevated because of hypoxemia. So if we're having a really hard time oxygenating the patient, it will make their pulmonary artery pressures go up. Remember, hypoxemia causes elevated PVPs, but they don't always have hypoxemia, depending on whether or not we can oxygenate them. So write the word variable in there.
I was gonna ask that for PCWP also.
And then for PCWP, I have normal. Yeah. Cardiac output's not affected. Systemic vascular resistance is not affected. Mean arterial pressure not affected. So you can just put a little dash in each one of those boxes. CO, put a dash. SVR, put a dash. MAP, put a dash. So when you're looking at a scenario and you have to say what, if it's ARDS, if it's left heart failure, those are the things you're looking for. All right, the next one is septic shock. And the body's response to a massive infection in the body is you get vasodilation everywhere. Patient in septic shock is going to have a really low blood pressure. So you'll see them come in really low blood pressure. They put them in Trendelenburg, trying to improve perfusion to the brain. Septic shock. So with septic shock and everything leaking, you also have capillary leakage in the pulmonary capillaries, and there will be pulmonary edema. So yes to the pulmonary edema. Pulmonary artery pressure, write the word variable. That's not really a telltale sign of septic shock. The pulmonary capillary wedge pressure can be normal or it can be low. So write in that box, normal or low. So the body responds to septic shock by causing a fast increase in the heart rate. So they're typically tachycardic, which causes cardiac output to be up. So cardiac output, put an arrow up or write the word increased. And that massive vasodilation that I told you about causes the systemic vascular resistance to be really low. And same thing with the blood pressure, really low. So those are the telltale signs of septic shock. Really low blood pressure, pulmonary edema, and a really fast heart rate, a high cardiac output. All right, the next row is hypovolemic shock. So when there's a large amount of blood loss from the body, there is no pulmonary edema on X-ray, so put no in that box. Arrow down for pulmonary artery pressure. Arrow down for wedge pressure, because that's going to be low. Cardiac output's going to be low because of that loss of blood volume. But the body responds by constricting the vessels. So it notices that it doesn't have much blood volume. So what can it do to try to get that little bit of blood volume to go to the necessary organs? So you'll have a high SVR. So hypovolemic shock, the response is constrict the vessels, try to get blood to flow to the major organs. All right, next one is pulmonary embolus. So that's when you get blood clots forming and they get lodged in the pulmonary vessels. So blood clots can form like in the legs and travel up. It gets into the right atrium, that's real big, nothing happens. The blood clot goes to the right ventricle, nothing happens. Goes into the pulmonary artery, and then as the vessels start getting smaller and smaller, the blood clot gets wedged in some vessels and blocks off the vessels. There won't be pulmonary edema. So no to that. If there's enough blood vessels blocked off by the blood clots, it will cause pulmonary artery pressures to be elevated. So you could put an arrow up for PAP. We're going to assume that there's a bunch of blood clots. So it blocked off a bunch of vessels, and now all the blood gets diverted over to the few vessels that are not blocked, and it makes the pressures high. Normal wedge. Cardiac output is variable. Normal SVR. Normal blood pressure. So your only telltale sign for a pulmonary embolus is that everything is normal, but the pulmonary artery pressures are high. The last one is mechanical ventilation with PEEP. Okay, A-lines and balloon pumps. Have you drawn any arterial blood from an A-line yet?
Yes.
You did, you did? Anybody else?
And then
Yes. No? Taylor did? All right, very good. Was it was there a reservoir where you pull the blood into a reservoir? Okay, that's known as the VAMP system. So it used to be before they had that reservoir, you would draw 10 cc's of blood and throw it out, because that first 10 cc's of blood has heparin in it, because heparin is always infusing into that line to keep it clear of blood clots. So you can't just draw the arterial blood, because heparin has a pH of 7.0. So it messes up your pH from your blood gas. You get inaccurate readings. So what do you have to do? Get rid of the blood that has the heparin. And in the past, you throw it out. So patients that had, 2 and 3 ABGs, venous blood being drawn, it was all their blood was going into the garbage. And then they'd have to get a blood transfusion. So now you pull back the blood that has heparin mixed in it, draw your fresh arterial blood sample, and then put that heparinized blood back in. So patients aren't needing as many blood transfusions now. All right, so we'll go through the setup of what an arterial line looks like. It's a Teflon coated catheter, and having Teflon on it, it prevents blood clots from sticking to the outside of the catheter. It measures a patient's arterial blood pressure continuously, which is displayed on the bedside monitor. So once a shift, they'll take a regular sphygmomanometer, check the blood pressure, and compare it to what they're seeing on the monitor to make sure that it's reading accurate. And they meaning the nurse. So the A-line acts as a site for drawing blood, including ABGs. So you don't have to stick them for venous blood. You don't have to stick them for arterial blood. You just draw the blood from the A-line. And then it says it's placed by percutaneous puncture or a surgical cut down. So a percutaneous puncture is a kit where it kind of looks like you're drawing the arterial blood. So you'll put the needle into the artery, and then you take the needle out, but leave the outside sheath inside the vessel. That's done by respiratory up in the middle of the state. But down here, it's not done by respiratory. It's done by the intensivist. Surgical cut down, if nobody can feel the artery, can't get the catheter in, they'll cut the skin, open it up, and visibly look for the artery and cannulate it, and then sew the patient's skin back together. So who gets an A-line? Patients who are difficult sticks. So if you're trying to get the blood gas, you can't. Chris?
the catheters they use for that, are they self-occluding or once it's placed and they start bleeding out and see? But how do they stop?
How do they stop the blood from gushing out?
Right.
Probably a cap. I'm not sure.
I ask because we use the catheters we use when we're doing blood draws are self-occluding. But this seems to be a little bit different. And the ones we use, so I just wondered because you have to thread something through the catheter, right? Put that A-line in. The catheter is on the outside of the needle. Yeah.
So when the needle goes in, you take the needle out, the catheter stays in.
How long is those A-line catheters?
I don't know.
I thought they might thread like a second catheter through the initial catheter, something longer, like a decline.
Yeah, you can check on YouTube for arterial line placement, and you can watch a video of it being done. I don't include it here because we as respiratory therapists don't do it down here, so there would be no reason to teach it. If a patient is hemodynamically unstable and they need medicine for low blood pressure, high blood pressure, it's good to have the A-line in place so that meds can be given to control the blood pressure. So here's a list of the equipment needed, but I just want to show you the setup. So the catheter sits inside the radial artery, and then the catheter is connected to a stopcock so we can draw blood from it. The catheter continues to a transducer that sits at the side of the bed, and I'll show you a picture of what that looks like coming up. So what a transducer is it'll take the pressure of the blood pushing against it and turn that into an electrical signal so that you can see that on the monitor. So that's what a transducer does. Takes the pressure from the blood, turns it into an electrical signal, and that's what you see up on the monitor. So coming into this catheter is heparinized saline, and it has to be put under pressure because of the high pressure in the arterial blood. It's different than putting something into a vein, because a vein is very low pressure. You don't have to worry about venous blood coming back up into the tubing and going up into your bag of medicine. But arterial blood is high pressure, and you need to have something to counteract that high pressure in the artery. So it'll be, you'll see a pressure bag around this bag of saline, and it'll push the heparinized saline through the catheter to prevent blood from coming backwards. So it's that heparinized saline that contaminates everything, and that's why you can't just draw from the line. You have to get rid of like 5 cc's first, not get rid of. Put 5 cc's into the reservoir first and then draw your blood.
No, they deliver it. Because, that's kind of really capillary before it heads back to the heart for systemic distribution. I thought they would only do that 7 runs to, into bands because they're now back to the heart. I didn't know that.
This is what you're going to see the side of the patient's bedside. So here it's red, arterial, and this is the transducer that takes the pressure of the blood, changes it into your electrical signal, and then you'll see this wire going to the cardiac monitor. There's something else on here that you interact with, and it's the pigtail. So it's blue and it just looks like a circle looking at it two-dimensional, but it actually sticks out like a piece of rubber. And when you pull on it, it'll cause that heparinized saline to flush through and get rid of any blood that's still left in the line after you've drawn your blood. So you pull on the pigtail to clear all the blood that was in the line and push it back into the patient's artery. The transducer level determines the accuracy of the reading. So if you have the transducer at the level of the right armpit, nope, it doesn't matter what armpit. At the level of the armpit, it's level with the base of the heart, and that's going to give you the most accurate reading. But if the transducer is down here and the patient's up in the air a lot higher than the transducer, now you've got gravity pushing against that transducer, and the pressure readings are going to be much higher than actual. Now, let's say the transducer is up here and the patient's down here. Now you've got the blood trying to push up towards that transducer, and gravity is going to pull it back down. Now you'll have a much lower blood pressure. So the level of the transducer compared to the right atrium, what is that called? The phlebostatic axis. But that determines the accuracy. All right, so what can you write on your paper? It asks you what happens if the transducer is lower than the right atrium. So the transducer's down here, the right atrium is up here. What is that going to do to the accuracy of the reading?
It's lower.
Right, it'll give you a higher pressure reading than normal, than actual. Oh, I'm not sharing screen anymore? So I wrote, if the transducer is lower than the patient, this will cause higher than actual blood pressure reading. So what's a good way to remember it? Transducer low, pressure high? Okay, and then the opposite. Transducer high, patient low, you're going to have low blood pressure reading. So if the transducer is higher than the patient, the blood pressure will read lower than actual. Any questions on that? So if you come in the room and you look up at the monitor and you see blood pressures like 80/50, like, oh, wow, that's really low. But then you look at the patient and the bed has been lowered way down and the transducer's up here, and you're going to realize that that's not an accurate reading. Okay, when you look at the waveform for arterial blood pressure, of course it goes up during systole because pressure goes up, and then during diastole, when the heart's filling, the pressure goes down. We know that. But it's got a dichrotic notch that I want to show you. So do you see this little blip in the waveform? That's when the aortic valve closes and it shows up on your tracing. So it's called the dichrotic notch, is when the aortic valve closes. And this is just another picture. Do you remember we talked about EKGs are only looking at the cardiac conduction of the heart? It has nothing to do with how well the heart is contracting. So is that come to mind when you look at this tracing? You see the ventricles depolarizing, and it's after that that they contract, and now we've got the arterial pressure increasing. Oh, here we go. Venous arterial blood management protection is how the words that they use to come up with VAMP, but it looks like a vampire, which is really cool. So as far as the procedure, like how do you draw arterial blood from this? Once you pull blood into the reservoir, you turn off the stopcock, and then you can put your syringe into that, into the port. It doesn't want me to, see if I can move this out of the way. You put your needle into the port, and you can do it a couple ways. There's a needleless cannula, and it's meant to protect you from getting stuck with a needle. And sometimes the hospitals don't have it in stock, and you end up putting a needle in here anyway. So when you guys did draw with the system, did you have the needleless cannula to put on the end of the syringe?
Yes.
You did? Okay. Okay, and then once you draw your blood, then you're going to push this reservoir blood back into the patient. So you would open up that stopcock and push it back in. But now you've got all this blood sitting in the IV tubing. How do you get rid of it? Very good. You flush it, you pull on the pigtail and flush it. What can cause inaccurate readings of looking at an A-line? If the catheter is not sitting in the vessel straight, then it can be hitting a wall, and then that can cause weird pressure readings. It can become kinked. That can cause weird pressure readings. The nurse will calibrate the line once a shift. And what are some other questions you're asked? What are some complications of having A-lines in a patient? The tubing can become disconnected and they can bleed. So that's one of the complications. Another complication is infection can set in. And a third complication is blood clots can form. All right, so that's it for A-lines. Sometimes patients have their venous blood being monitored and the saturation, the oxygen saturation of venous blood being monitored. What would be the point? Like, why monitor venous blood? We really care how much oxygen we're delivering to the tissues. Why would we bother measuring venous blood? So the answer to that is, if the cells are starved of oxygen, they're going to end up extracting more than the normal amounts of oxygen from the hemoglobin. And in the venous blood, we'll notice that our venous oxygen saturation is lower than normal. It could be because blood pressure is really low or cardiac output's really low. For some reason, the cells are just not getting enough oxygen delivered to them. So the little bit of blood that does get delivered, they end up taking more than the normal amounts of oxygen. And then our venous oxygen level will be lower than normal. So first, we need to know what normal is. Anybody recall a normal mixed venous PO2?
Is it like 75%?
75%, very good. And what about the PO2? No? 40 millimeters mercury is a normal venous PO2, PVO2. 40 millimeters mercury. How can you tell if you drew an arterial blood sample, but you accidentally drew a venous blood sample?
It'll show the venous blood.
Very good. The saturation would be near 75%. And that would tell you that, nope, it's not arterial. You hit the vein instead. So anytime the saturation is near 75%, you need to redraw that blood sample because you probably drew that from the vein instead of drawing it from the artery.
When I've seen some therapists just look at it and they're able to tell, I'm like, how do they do that?
Oh, if it's bright red versus the dark red. What is a true mixed venous oxygen sample? Or where would you draw a true mixed venous oxygen sample? I think they ask you this on your national exam too. Where would you draw a true mixed venous oxygen sample? So it needs to be a blood sample that represents the entire body. So you need blood from the head, blood from the lower body, any shunting going on the right side of the heart. So that would put us at the pulmonary artery. So if you needed to draw a true mixed venous oxygen sample, it would come from the pulmonary artery. So where would you draw a mixed venous blood sample from? Very good. A Swan-Ganz catheter. And then it would be from the port that's sitting in the pulmonary artery.
That's what I was gonna say, just, the right atrium. There's no way to draw it from the right atrium.
Yes, there is, and it would be the Swan-Ganz catheter, or if they have a CVP line in. But not a true mixed venous gas. So if there's any shunting going on in the heart, it would make a difference between right atrium and pulmonary artery. Is it possible to monitor continuous venous blood saturation? The answer is yes. There's a special Swan-Ganz catheter that allows you to continuously monitor venous O2 sats. Name 3 causes of lower than normal venous oxygen. The first one is poor cardiac output. So does that make sense? You're not delivering enough blood to the tissues, so they take out more than normal amounts. Second one, if you start off with low amount of oxygen, so arterial hypoxemia. And the third one is low hemoglobin. So if you don't have the ability to carry that oxygen to the tissues, your venous O2 sats will be lower. Do you know the answer to that question at the bottom? What could cause metabolic acidosis to show up on the arterial blood gas if a patient has poor perfusion to the tissues? Why would you get a metabolic acidosis if you have a poor cardiac output? What else? Yes. So when there isn't enough oxygen in the tissues, anaerobic metabolism occurs and lactic acid is formed. So low oxygen to the tissues, lactic acid forms, and that gives you metabolic acidosis. I think I'm using too many fancy words here. So low O2 to the tissues causes the tissues to create energy using anaerobic metabolism. Okay, anaerobic metabolism creates lactic acid. So lactic acid forms. Lactic acid forms, and that's what causes metabolic acidosis. So put some stars by your notes, because this is really important. Respiratory is asked often to check lactic acid levels. So you have to understand why you're checking lactic acid. They're looking at oxygen delivery to the tissues. If it's adequate, then you won't have lactic acid buildup. If there's a lot of lactic acid, you're not getting enough oxygen to the tissues. So they probably do that way more than they have a special catheter sitting in the pulmonary artery measuring venous O2 saturation.
What's the normal lactic acid range?
Can you look it up and we all can write it down?
I think it's like 3.0.
Did you find it?
I don't know if this is right. It's saying 4.5 to 19.8 milligrams per deciliter.
Is that just from Google?
Yeah.
Did you guys have to know this as one of your lab values?
We totally.
I think.
And it was probably different than 19?
2.2 millimoles per liter. I think that's right.
What is it?
Kim has 0.5 to 1.6 MEQ for
Milliequivalents?
million.
Less than 2? Okay.
Thank you.
Is it MEQ per liter or millimoles? Oh, really? Millimoles. Okay, so less than 2.
No, it doesn't use 0.4 every 30 minutes at one.
If it sits at room temperature, it increases? Ah. Wow.
It's a big difference. The normal is on 2.
Yeah, that's true. Yeah, good point. And sometimes the cells don't extract any oxygen because of severe sepsis. Cyanide poisoning poisons cells so that oxygen can't be utilized. If there's a high amount of carboxyhemoglobin, the cells will not release their oxygen to the tissues. And one more, that if the patient is being over-oxygenated, their venous PO2 will be high. All right, so that was it for normals for venous blood, and now we move on to balloon pumps. IABP. So can we get through this in 7 minutes? Okay. So a balloon pump, maybe you saw it on your patients if you were in CVICU or the heart surgery unit. Has anybody rotated there? HSU,
CV, right?
CV? No?
I've had to transfer
I've been there,
patients
but
on these.
Yeah, normally they don't go to the CV.
Oh, okay. So there's a big machine that sits at the bottom of the patient's bed, and there's a big catheter that goes up their femoral artery, and the catheter sits in the descending aorta. And it's about a foot long, and it's got a balloon on it. And when the heart is in diastole, it inflates. And then right before the heart contracts, it deflates to let the blood get past it. And then it reinflates. So why in the world would they want to stick a balloon in somebody's descending aorta? And the answer is it helps relieve afterload, or it relieves the work of the heart. So that's the reason for a balloon pump, is that it relieves the workload of the heart. So when the balloon is in the aorta and it's inflated, blood can't be there. So there's no like resistance to the heart when it contracts. Go ahead, Chris.
I was just saying, it delivers like a second contraction or heartbeat almost, pushing blood forward. And
Yes.
then, like you said, it inflates again, so that no blood can come back into the heart. So the heart doesn't have any afterload, just send it to push against.
Yeah, and then you mentioned the other way that balloon pumps help. When that, pardon me, when that balloon inflates, it does push the blood in the aorta through the coronary vessels. So it does help with coronary perfusion. So that is the second. Okay, so now for the notes.
That machine weighs 100 pounds.
Is it really?
That's
And you can see the back of the machine, what gas they're using to inflate the balloon. Why do you think it's helium and not air?
lighter and it can travel faster. And it's doesn't do. I don't think it does as much damage as it does rupture.
Very good. So you don't get air boluses, air emboli forming in the blood vessels if the balloon did rupture and there is air in there. Air can actually be an occlusion, just like a blood clot can be an occlusion. An air embolus can be an occlusion, and it can stop blood from flowing. So if the balloon were to rupture, it would create this air embolus, and it would just stop blood from flowing. So you need a gas that diffuses easily. It doesn't form a big bubble, but it diffuses, and that's helium and carbon dioxide, I think. All right, so the balloon pump inflates at the beginning of diastole. It deflates during systole. It will increase mean aortic pressure and coronary blood flow to the myocardium during diastole. So I'll let you guys click on this link when you're reviewing your notes so that you can see the balloon pump in action. So this picture is showing how they thread the catheter up into the descending aorta, and that's where they leave the balloon. And then once the balloon is in place, you see it here? It just sits there. Inflates during diastole, deflates during systole. Cute. When you're looking at the blood pressure waveform, it's kind of weird. It's got 2 pulsations of blood. So when the balloon inflates and it pushes more blood into the aorta, into the coronary vessels, you'll see the pressure is a little bit higher than it was prior to the balloon inflating. So it helps the heart in 2 ways. This is a test question. It improves coronary perfusion by inflating at the end of systole and forcing blood into the coronary arteries. Secondly, it lowers systemic vascular resistance by reducing afterload on the heart. And then this will result in less workload on the heart and less O2 consumption. So who gets a balloon pump? A patient who's in cardiogenic shock. So the ventricle is just not pumping effectively to support life. So it's either let them die or let's put a balloon pump in, let their heart rest for a few days, see if the heart can start working normally again. So a lot of times after open heart surgery, the heart is kind of in a shock and it doesn't contract the way it should. So they'll put a balloon pump in right after their cardiac surgery. Okay, and then there's one more piece of information you need to know about balloon pumps. And that is the ratio between how many times the heart beats and how many times the balloon inflates. So it's set for inflation every single heartbeat. It's called a 1-to-1. So for every heartbeat, the balloon inflates. And then as the heart starts getting better, they'll reduce it. It won't be 1-to-1 anymore. It'll be 1-to-2, 1-to-3, 1-to-4. Once it's once every 8 heartbeats and the patient's still doing fine, that indicates they can get rid of the balloon. So 1-to-1, balloon inflates every heartbeat. So 1-to-8 means the patient's doing better and it's time to take the balloon out. Where is the balloon pump catheter placed? Do you know the answer? It's threaded up the femoral artery, and where does it sit? Descending aorta. So put that in the blank line. And the balloon has to be high enough up so it doesn't block the flow to the kidneys. Another problem, respiratory related, is the patient has to be flat. Like they can't sit because it kinks the catheter. So they have to keep their body straight. So that you can do like a reverse Trendelenburg where you can have their head up, but their body still has to stay straight. Sometimes it's hard to wean and extubate a patient if they have to stay flat. So that's difficult. Blood must be heparinized. This keeps getting in our way, doesn't it? Blood must be heparinized to prevent clotting around the balloon catheter. So if a patient has a balloon pump in and you get an order for a blood gas, is it okay to go to the patient's artery and stick the artery to get your blood gas? Marlon, what do you think? Yeah, you guys really have to pay attention to this because you could kill somebody if you don't listen to this. Patient has a balloon pump in. Their blood has to be completely heparinized so that it doesn't clot around this big balloon sitting in their aorta. Completely heparinized, meaning their blood will not clot. If they get a cut, if you poke them with a needle, it'll never stop bleeding. So if there's a patient on a balloon pump and you get an order for a blood gas, is it okay for you to go to that patient and stick their radial artery to get your blood gas? No. Are you sure you're listening? Everybody heard me?
Yes.
All right. So if somebody's completely heparinized, you can't draw arterial blood from them. Same thing with streptokinase. It completely prevents any blood clots from forming. If you stick them with the needle, they just keep bleeding and bleeding and bleeding. So you gotta make sure you're listening, right?
In that situation, would they have, you know?
Yes, there's an A-line on the balloon pump. tubing catheter. So yes, you can draw from it.
So Ron, when they start to like wean them off the balloon pump, they just start to give them less heparin.
Yeah. Yeah,
So
we'll
it's
just
still-
stop the
It won't
heparin.
necessarily clot that fast. Around the balloon pump.
Once,
Like how long does it take them?
no, so the balloon has to be out of the body. And that's when they stop infusing the heparin. Now, how long does it take for the patient to clot normally after they've stopped the heparin? I don't know, is that 24 hours, 38 hours? I'm not sure.
But if they take it out of them, once they start bleeding from the brain.
Yeah. Yeah, so what they do is they have heavy, pressure things, I'll call it. Almost looks like a brick that they put on the femoral artery. And then they bandage it really good. And all that pressure will prevent most of the bleeding, but it will still ooze.
Almost like a tourniquet in a way.
Yeah. Question?
Oh, yeah, I was gonna ask, so if their blood is completely hepatized, it must be difficult to get an accurate ABG if you get it from the artery. Forget what what's the line called again? The A line.
So drawing from the A line, it would be the same procedure. Drawing from the A line with the balloon pump, it's the same procedure. Where you waste some of that heparin in the line and just draw the fresh arterial blood. Having heparin in the patient's blood, will that change the pH? Yes, but it'll be accurate.
Oh.
Because it's the patient's blood. It's not heparin that's in tubing. Question?
So a patient, this is just a side question I have. So it says blood must be heparinized to prevent clotting, so the patient be on like a heparinized saline. Okay.
No, the heparinized saline drip, it keeps the line from clotting.
Mhm.
And then, yeah, so yes, I'm thinking pressurized, heparinized saline, yes. Yeah, so that's what they use to keep the blood from clotting. So when patients have a balloon pump put in, it's possible that the blood flow to the leg, where the femoral artery has been catheterized, they can have poor blood flow to their leg, and they can actually have to have their leg amputated because the tissue starts to die. I know that's not a nice complication, is it? Another complication is they can hemorrhage because all of their blood is heparinized. And then, of course, anytime you have a catheter going through the skin and into the body, it opens up the possibility for bacteria to get in and start growing. Okay, we did it. 2:07. All right, I'll stop the recording. You guys can take a quick break and then we'll start with your teams going through ACLS.
So what do I do for a team?